Okay, guys, sorry about that. Not sure what happened. I think I exhausted my time on the computer here. But we left off at, I was talking about speech patterns. We'll go on to cognitive functioning. So the onset of bipolar is preceded by comparatively high cognitive functioning. However, there is growing evidence that about 1/3 of patients with bipolar display significant and persistent cognitive functioning and difficulty in psychosocial areas. Cognitive deficits in bipolar are milder but similar to those in patients with schizophrenia. Cognitive impairments are greater in bipolar 1, but are also present in bipolar 2. So we talked a little bit about these speech patterns: pressured speech, circumstantial speech, tangential speech, loose associations, flight of ideas, and clang associations. Okay, so let's see. We talked about pressured speech is like the frantic and rapid speech. Tangential speech is speech that will go off of topic. When a person is speaking, they'll go off of topic. For example, if a person is talking about, if you ask them if they have a dog, and they'll say, start talking about their childhood dog and their neighbor's childhood dog and going all around the world, and then they come back and answer the question. Similarly is circumstantial speech. However, the individual generally does not come back to topic. Loose associations, we talked a little bit about, as well as clang associations, flight of ideas, shifting from topic to topic is flight of ideas. The example in lab where our gentleman Gary was talking about the mating habits of geese and golf and extraterrestrials, that's a flight of ideas. Thought content, you're assessing for grandiose delusions and persecutory delusions. A grandiose delusion being very exaggerated, elevated. I think we discussed that a tad bit. The person who believes that they're next in line for presidency. And persecutory delusions believe that someone is out to persecute them. For example, the FBI is going to persecute or convict you for attempting to save the world from mutant mice or something like that. That's a persecutory delusion. Okay, let's skip over this. So self-assessment. So I talked a little bit about this, how bipolar patients with bipolar disorder, can be challenging to work with. And again, we talk about this self-assessment, checking in with ourselves. The manic patient can be manipulative, demanding, and split. Splitting is defined as going to think about a child who they go to one parent, that parent says no, they go to the other parent, that parent says yes, and then they're splitting those two. That's splitting. They go to one staff and they may sing the praises of this staff in an attempt to gain something from them that the other staff has already set a limit on or said no to. That's splitting staff. Getting staff to do just the opposites. That's splitting. So the staff member action, staff should always have frequent meetings to discuss the patient's behavior so that everyone is on the same page, and set firm and consistent and neutral limits on a regular and again consistent basis for this manipulative patient. And also again be checking in with oneself to ensure that the patient is not getting the best of you mentally or triggering. So assessment guidelines for bipolar disorder continue. You want to assess if that individual is a danger to self or others, the needs for protection from uninhibited behavior. So again, that's sexual recklessness, or that increased energy, that lack of need for sleep. You are the professional, the provider, the caretaker that want to protect essentially the individual from themselves, from their own, I hate to say it, but reckless behaviors. So the need for hospitalization, medical status, coexisting medical conditions, and also assess for the family or caretaker's understanding level. So the nursing diagnosis for bipolar, you have the risk for injury, risk for violence, other directed or self-directed, ineffective coping. So with these nursing diagnoses, as we go through these disease processes, each one will not apply, but these are examples of nursing diagnoses that would potentially apply based on how the patient is presenting at the time. Forward to the outcomes identification in the nursing process. Acute phase, you want to prevent injury. Continuation phase, you want to prevent the relapse. In the maintenance phase, you want to limit severity and the duration of future episodes. For planning, we think about medical stabilization, maintaining safety. Nursing care, we want to manage medications, decrease physical activity, increase food and fluid intake, ensure at least 4 to 6 hours of sleep per night, and intervening so that self-care needs are met. Seclusion, restraint, or ECT, or electroconvulsive therapy, may be considered during the acute phase. I haven't seen that much in practice, but it is possible for a severely manic patient. So planning in the acute manic phase, you want to stabilize the individual medically. Again, if that person has not been sleeping, has not been eating, and we've reached the point of a potential emergency, we want to medically stabilize them, maybe provide some fluids, supportive care, and ensure that the individual has the opportunity to rest. I know that I've heard in severely manic patients, for example, who present to university hospitals, they can at times be sedated so that they are able to rest and their bodies are able to recover. Maintaining safety, inpatient hospital nursing care if necessary. Seclusion, restraint, or ECT may be considered again during the acute phase. Managing medications, decreasing physical activity, increasing fluid and fluid intake, ensuring 4 to 6 hours of sleep per night, intervening as self-care so that self-care needs are met. Okay. These are objectives. Okay. Where are we? Okay. Implementation, depressive episodes, hospitalization for suicidal, psychotic or catatonic signs, medication concerns about bringing on a manic phase. So I believe I've talked about this, I'm not sure in lab or if in clinical. However, when an individual is in a depressive episode or an individual specifically with bipolar disorder, which again has these two components, mania and depression. If they are in the current phase of depression and are medicated for depression, many of the depression medications can cause a sudden onset of mania once that depression lifts. So as a result, providers, caretakers, prescribing clinicians have to be very, very much so aware of the medications that do so and prescribe those that are specific to depression associated with bipolar. One of the most common ones we use is Lamictal. And so that's what that point of medication concerns about bringing on a manic phase, because literally once that depression is lifted, the person can go into full-fledged and severe mania. With manic episodes, we want to hospitalize for acute mania, which is typically in that bipolar 1 disorder, communicating challenges and strategies. Pharmacological interventions are focused on two main elements, the agitation as well as the mood stabilization. Okay, Okay, so individuals with bipolar, we talked about those nursing diagnoses, the ineffective coping, risk of harm to self or others. They will typically present, and we want to treat their agitation and their mood lability, or we want to stabilize their mood. Okay, that's done so by a subset of medications. Lithium is indicated for bipolar disorder. The book describes it as the first line treatment. However, lithium is a very serious medication. It has very severe and potentially toxic, as you'll see here, toxic side effects. Okay, so we don't always use this as our first line. Generally, the way that I see it prescribed is when all other therapies have failed and you're dealing with individuals who are experiencing severe and acute exacerbations of mania that are grossly impacting their daily functioning and their ability to live a normal life. So lithium is again, it is indicated for bipolar. It's pretty much its own class of medications. Let's go here. The book says it's effective in the treatment of bipolar 1, acute and recurrent manic and depressive episodes. It inhibits about 80% of acute mania and hypomanic episodes within 10 to 20 days. Lithium is less effective in people with mixed mania. That's the one with the rapid cycling, but again, it's very, very effective in treating mania. It's particularly effective in reducing elation, grandiosity, expansiveness, flight of ideas, irritability, manipulation, anxiety, and to a lesser extent, controls insomnia, psychomotor agitation, threatening or assaultive behavior, distractibility, hypersexuality, and paranoia. It must reach therapeutic levels in a patient's blood to be effective. Okay, let me stop right there. So these are your therapeutic and toxic levels. Please memorize this information. Your therapeutic blood levels 0.8 to 1.4. Maintenance 0.4 to 1.3. Okay, milliequivalents per liter. Please commit this information to memory. You will see it again in this course. You will see it again likely on your NCLEX, okay? Especially this toxic 1.5 milliequivalents and above. So let's stop and think about that. Individual who is frequently in manic episodes of bipolar. As I stated before, individuals love mania. I mean, just clearly speaking, at least the beginning phases of mania. It's enjoyable. Who wouldn't enjoy that? Okay, so lithium primarily treats that. Individuals with bipolar do not like lithium. Okay, they don't like it. So the likelihood that you reach and maintain an adequate blood level is up for debate, okay? But also this toxic level, when you have someone who may or may not be adherent to medication, you want to be careful. You really want to be careful, because how adherent are they going to be to having these frequent and regular blood draws, which is what needs to happen to monitor for something that can potentially be toxic. Okay, so keep that in mind. Please keep that information in mind. If you have any questions, feel free to reach out to me about it. Let's see if there's anything else that I would like to touch on. Anything else that I would like to touch on? I would like for you to read about lithium on your own on page 239 and page 240, please. Read about lithium. Oh, let me go back. Okay, let me go back. And then in box 13.1, patient and family teaching on lithium therapy. Okay, I'm going to run through these. The patient and patient family should receive the following teaching and be encouraged to ask questions and given the information in the written form as well. Lithium treats your current emotional problem and helps prevent relapse. Therefore, it's important to continue taking the drug after the episode is over. Therapeutic and toxic levels are so close, so it's important to monitor lithium blood levels very closely, more frequently at first, but then once every several months after that. Lithium is not addictive. It is important to eat a normal diet with normal salt and fluid intake. Lithium decreases sodium reabsorption in the kidneys, which could lead to a deficiency in sodium. A low sodium intake leads to a relative increase in lithium retention, which could produce toxicity. You should stop taking lithium if you have excessive diarrhea, vomiting, or sweating. All of these symptoms can lead to dehydration. Dehydration can raise lithium levels in the blood to toxic levels. Okay? Do not take diuretics or water pills while you're taking lithium. Lithium is irritating to the lining of stomach. Take lithium with meals. It is important to have your kidneys and thyroid checked periodically if you are taking lithium over a long period of time. Do not take over-the-counter medicines without checking first with your provider. If you're gaining a lot of weight, talk to your doctor or nutritionist. Many self-help groups are available. Keep a list of side effects and toxic effects handy. If lithium is discontinued, your dosage will be tapered down gradually to prevent relapse. Okay, so this is a very, very serious medication. I want you guys to know side effects and signs of lithium toxicity. Okay, that's in table 13.3. I want you all to be familiar with this information, as well as the teaching information, which I just went over with you, as well as therapeutic and toxic levels, not only for this class, but for your ATI proctored exam, as well as NCLEX. So Ms. A has started on lithium, discuss what you should be teaching, and provide before she's discharged. Again, we just went over that. That is on page 241 in box 1311. So anticonvulsant mood stabilizers, mania and depression, they're complete opposite sides of the spectrum. When you think of mood stabilization, you think of right in the center. Okay, so Depakote, Tegretol, and Lamictal are used. These are also anticonvulsants. They're used to treat seizure disorders, but they work well. So Depakote, Tegretol, and Lamictal. Tegretol is generally what I see in practice as a first line. I see a lot of Tegretol even used in adolescent patients who are diagnosed with bipolar disorder. You'll see adolescents diagnosed with bipolar, not so much with schizophrenia. Schizophrenia, you can be diagnosed as early as 12, as we talked about early onset, general onset between 15 and 25. However, you usually don't see a diagnosis until like the early to mid 20s. They like to delay the diagnosis as long as possible to prevent misdiagnosis. But which we'll later learn though about the disproportionate diagnosis of people of lower socioeconomic backgrounds, as well as people of color with schizophrenia, as opposed to other mood disorders such as bipolar or other inorganic disorders or inorganic psychiatric disorders. So anticonvulsant, again, mood stabilizers, Depakote, Tegretol, and Lamictal. Lamictal is really good to treat the depression associated with bipolar, and preventative for swinging into that mania, which we talked about. Also used are second generation antipsychotics. Second generation antipsychotics are used commonly to treat individuals with bipolar. So this is a listing of them. I will provide you all with a listing of all of these psychotropic medications, not just antipsychotics, but all psychotropic medications in general. Okay, so be familiar with these. Pay attention to your study guides. I tell you exactly what you want to know, which ones you want to be familiar with. And table 13.4 on 243, it outlines these listed. But on your study guides, I tell you exactly which ones you want to familiarize yourself with, which ones are the most important to familiarize yourself with. And these are the first generation antipsychotics, the stronger ones with the higher side effect panel. Okay, so we're going to evaluate specific indications for the use of seclusion and discuss ECT. So I don't see this very commonly, ECT and seclusion, in individuals with bipolar specifically. Okay, not saying that I don't see it, but I don't see it specifically. But here, ECT, teamwork and safety, seclusion protocols, safe support groups, and health teaching and health promotion. These are your advanced practice interventions: cognitive behavioral therapy, interpersonal social rhythm therapy, family focused therapy. And for evaluation, we want to evaluate the outcome criteria, reassess the care plan, and revise the plan if indicated. Quality improvement, you can read that on your own. And for your audience response question, which anticonvulsant medication may be prescribed for a patient with bipolar disorder? The only anticonvulsant up here is a Depakote. Okay. Klonopin is a benzodiazepine. All the benzodiazepines end in PAM. So, for example, Ativan is lorazepam. Okay. Clonazepam is Klonopin. It's a benzodiazepine. It's an anxiety agent. Olanzapine or Zyprexa is an antipsychotic. And lithium, like we talked about, is first line, quote, first line treatment for bipolar. And that is it. Thank you very much for your attention. Please email me if you have any questions. I would like for you all to pay special attention to your study guides. I would like you all to, of course, read the chapter on your own as you're working through your system-based disorders. Please, again, let me know if you have any questions. It's pretty straightforward, but if you have any logistic questions or any questions about how I want it done, please let me know, but just do the best that you can. It's pretty straightforward, and it'll give you some great reference material as you're studying for your bipolar and your schizophrenic disorders. Again, thank you very much. Email me if you have any questions, and take good care of yourselves always. Bye.